Good afternoon. It is my great pleasure to welcome everyone to Harvard School of Dental Medicine's Continuing Professional Education, CPE Today, talk number 5, titled Remote Orthodontic Care Beyond the Pandemic. My name is David Kim. I'm the Director of the Continuing Professional Education at Harvard School of Dental Medicine, and I'm very pleased to introduce our moderator, Dr. Katie Klein. Dr. Klein is a board-certified orthodontist and an instructor in the oral and maxillofacial surgery department at Harvard School of Dental Medicine. She is also the course director of the surgical orthodontic at HSDM and the co-director of the orthodontic surgical team at the Massachusetts General Hospital. Dr. Klein, the coronavirus pandemic has changed how dentists have been providing emergency and urgent treatments. Orthodontic patients require continuity of care at a scheduled time interval, and it appears that implementation of virtual consults and remote monitoring became the norm in dentistry. These technological advances may help us to reduce the number of patient visits to our office. It will be very interesting to us to see how our patient care has been modified and what we can expect in terms of the future of the orthodontic treatment.
Thank you, Dr. Kim. This has certainly been a challenging time for all of us in the dental field, and particularly orthodontics. Many of us have newly experienced taking care of patients through the computer and felt the frustration of wanting to simply reach through the screen and clip a broken wire, replace a missing O-ring, or just pop off that broken appliance. Clinical procedures that typically take less than a minute or two to manage in our office can sometimes take on a life of their own in a virtual platform and result in the expenditure of exponentially more time. Many of us have never seen more awkward close-ups of both ourselves and patients while attempting to look around the patient's cheek to actually see whatever it is they're trying to somewhat unsuccessfully show us. And many of us have never agonized more about the logistics of taking care of the staff members with whom we work so closely and appropriately outfitting our practices to meet guidelines and maximize patient safety. And most of us have never sweat as much as we do now under multiple layers of PPE. Despite all of these hurdles, my orthodontic colleagues have impressed me tremendously. They are simultaneously taking care of hundreds of patients with active appliances in place virtually, growing their practices by seeing new patients and discovering strategies for communicating competence and warmth across a digital platform, seeking out opportunities for increased professional growth through continuing education, and creatively thinking about ways to adapt and respond to this new situation and reimagine the future of orthodontic care. Orthodontists have pivoted well. It is my great pleasure to introduce our two presenters, my colleagues, who will provide timely and interesting insight into the practice of orthodontics, both during and beyond the COVID-19 pandemic. Dr. Mohamed Masoud is the Director of the Advanced Graduate Education in Orthodontics at HSDM and is a board-certified orthodontist. He has also served as an examiner for the American Board of Orthodontics. Dr. Negin Katebi is the Director of Predoctoral Orthodontics at HSDM and is a board-certified orthodontist. We want to note that today's presentation contains the opinions of our panel of experts, not those of HSDM. Drs. Masoud, Dr. Katebi, we will turn over our discussion to you.
Thank you, Dr. Kim and Dr. Klein and Dr. Katebi for being part of this. And I'm going to start out today by just disclosing that I don't have any conflict of interest with any of the companies that are mentioned in this presentation. I do have a patent on one of the methods that are mentioned. It hasn't been commercialized yet. So what we're going to talk about today is, I'll start out with a case that I treated a couple of years ago that taught me a lot about what is possible in a remote setting. And then from there, we're gonna move on to reflect and see what things we can do to set ourselves up better to serve our patients in situations where in-person appointments are not possible. So I'll start out with Celine. Celine, when I first saw her, was 11 years, 7 months old. Primary concern was labally positioned upper canines and crowding, no significant medical history. She had a history of trauma to her upper central incisors, which is related to her social history, which involved living on a 50-foot aluminum boat. So Selena's parents are explorers, and they're on a global climate expedition. And she spends months on end in the middle of the ocean. So in-person appointments were not really possible for her, at least not on a regular basis. In the panoramic x-ray, you can see she has quite a bit of crowding, blocked out upper canines, lower right first premolar, second premolars are developing, second molars are erupting, third molars are all developing. You see here on her Ceph, she's bimaxillary retrognaathic, skeletal class 2, very upright upper and lower incisors, hypodivergent. You can see that lower right first premolar is blocked out. Both upper and lower midlines are to the right of her face. The upper canines are blocked out. So this is a challenging case in any setting, even in in-person settings. It's a challenging case. And it's complicated by the fact that she can't come in regularly. So all the things that I would have liked to do for someone in her situation, using 2x4s or opening space for the blocked out teeth, or using some kind of growth modification or expansion. Those are things I was really reluctant to do on her because I knew I wasn't going to be able to see her more than 2-3 times a year. I didn't want her having to deal with an emergency that couldn't be dealt with if she's in the middle of the ocean. So we decided to treat her with clear aligners, even though at that time I thought it wasn't the best tool for the problem. And we had long conversations with the parents, and I explained to them that it would be an improvement. She signed on that in the consent form, that we would do our best, but it would be extremely unlikely that we'd be able to get an ideal result, given the fact that we're going to attempt to treat this case with clear aligners, knowing that it's not the best tool for it. In the setup instructions, we asked for 20 degrees of derotation and 2 to 3 millimeters of distalization of the upper right molar. We asked for some class 2 elastics, and what I was shooting for was to hit the labially displaced upper right canine against the lingually displaced lower right first premolar, and have her wear a reverse cross elastic to support the distalization and help with both displacements. I asked for both midlines to be moved to the left, and proclination of the upper and lower incisors both to make the bite shallower and to provide space for the blocked out teeth. And we asked for virtual bite turbos. Back then, this was before Invisalign MA was available, so we basically asked for virtual bite turbos, and we asked the patient to bite on the turbos to serve as a form of functional appliance, if you may. So this is the first clin check they gave us, and this is something you want to watch out for. Clear aligners is not, it might be less taxing on your chair time, but it involves, if you're going to do it right, it takes a lot more of your time in front of the computer. So the first clin check they sent us, if you notice here, the lower right first premolar was scanned. It was present clinically, but in the first clin check, you'll see that it's missing. And as they open spaces for it, as the clin check opens spaces for it, you eventually get a pontic to represent it. But that first aligner would not have fit if I approved the first clin check that we got. That's something to watch out for. You always want to make sure you check the clin check for teeth present in real life and present virtually. We had the same problem on the upper right. See that upper right canine was scanned, but it just wasn't there in the setup. For the upper left canine, again, it was present, but they gave us this pontic to represent where it is and allow it to erupt. For this Klein check, this was a later Klein check, a later version of the plan. And another thing to watch out for, here they gave us the impacted, the blocked out tooth. But as you see here, as it erupts, we all know that that tooth, the unerupted part of that tooth is wider. But here, as that tooth erupts, it gets narrower. So sometime around the liner 25 to 30, that aligner is going to stop fitting. So the software, the AI, the technicians, they're not the providers. You're ultimately responsible for the case, and the provider needs to watch out for stuff like that. The system can't treat patients without a provider at the wheel. This was like plan 7, and at this point I was pulling my hair because I kept asking for that rubber band cutout on the lingual of that lower right first premolar so I could use an elastic to help move that tooth labially. I knew that the aligners on their own were not capable of moving that blocked out tooth to the labial. I needed help from rubber bands. And at this point they gave me a pontic, which still didn't serve the purpose because I couldn't wear a rubber band to the tooth. This was plan 8 that we ultimately approved. So apparently they can't give you a cutout if the clinical crown's too short. See, at this point, they finally gave us the appearance of the crown, but the workaround was that we asked them to bring the gingiva higher. So to make the clinical crown shorter, not longer. What that does is, I know that that lingual part of that cusp is present clinically, so I would put a button on it, and the aligners just cover the buccal cusp. So it's a workaround, a limitation of the system. So that's ultimately the plan that we end up approving. See the midline swinging to the left, the teeth proclining, and that premolar moving to the labial. And on the right side, we get some distalization supported with a rubber band from the upper right canine that's buccal to the lower right first premolar that's lingual. So we started her January of 2017, and this is her in September. She's on aligner number 41 of 54. And at this point, she's lost a lot of her baby teeth. The first premolar is nicely in the arch. I had a couple of FaceTime meetings with her. This was before I knew of Zoom. Zoom might have existed, but I didn't know it was an option. But we did FaceTime, and most of the crowding's gone. At this point, she lost a lot of baby teeth, so we decided to scan for a refinement. We didn't continue beyond the liner 41. And the focus of the refinement was to get a little bit more distalization. The crowns of those upper centrals had tipped to the left, but the roots were still off to the right. And we wanted some extra space to give her some upper lateral incisor buildups. And we saw her again in October. She flew in just for to start the refinement in October. So it took us about a month to get her refinement ready. And this is after that first refinement. So this is after the second set of aligners. So this is June of 2018. You can see here the canines are in a good class 1 at this point. We built up her upper laterals that same appointment, and we scanned her for another refinement. The purpose of the second refinement was to fine tune the upper second molars. And at this point, we're out of the woods and we're just being picky and working on the details, getting the gingival margins right, getting the midlines a little bit closer, still tipping those roots of those centrals a little bit more to the left, and fine tuning the occlusion on the second molars. This was the pan we took at that second refinement, and we used it as her final x-ray, as her final set of radiographic records, because the fine tuning we were going to do was not something that was, we wanted to use the x-ray to guide us through the last refinement, and whatever changes we would make wouldn't really impact the x-rays. So we used these as our progress / final x-rays at this point. You can see here she grew quite a bit. Her profile's a lot more orthognathic. Her lips have a bit more support. Upper and lower incisors are nicely inclined. And growth definitely helped us. She was an amazing patient, and the upper and lower incisor inclination are giving the lips a lot more support at this point. These are her final photographs. She was 19 months in treatment. We had 6 appointments. The second refinement helped us get the occlusion a lot more settled. That's her before and after. And I learned a lot from this case. First thing was that I could do a lot more with clear aligners than I thought I could. And sometimes we need a challenge to kind of push us and let us know what is possible. And it's not easy. It was a lot of work between the initial clinch checks and then the refinements. We made it to 18. We went through 18 plans. So it might save you some time in the chair in the actual clinic, but it does take a lot of your time in front of the computer. And good, reliable patients can be seen less than usual, than what we're used to. Some level of remote care is possible, and we're going to need to embrace change, especially at this time. A lot of direct-to-consumer options are filling a need that the patients have, whether it's cost, whether it's time, whether it's availability. And I think we need to adapt and make sure that we're providing services that meet our patients' need while still maintaining our standards. And I just want to clarify that we're not talking about direct-to-consumer, because that has a lot of problems of its own. We're talking about remote care that still involves some procedures that are necessary to happen in person. You do need a clinical evaluation, a periodontal evaluation. You still need radiographs, things that often don't happen in a direct-to-consumer business model. You still need to evaluate the patient's profile and take that into consideration when you're deciding on your treatment plan. Most clear aligner cases require attachments and elastics and interproximal reduction and things that you can't do in a direct-to-consumer model. And finally, even the cases that you start out that you think are the most simple often involve problems, and troubleshooting is something that just doesn't happen with direct-to-consumer. So again, we need to be better at making sure we provide the level of care we want to provide or we need to provide, and still meet our patients' needs. So some of the things we can do better is planning our attachments in IPR around times when we know we're going to be able to see our patients in person. So for example, if we know our patients aren't going to be able to come in for another 10 weeks, we need to know that from the consultation, what their availability is or what our scheduling is like, and make sure that we plan attachments and IPR at times when we're going to be actually able to see the patients. There are a lot of tools out there that allow orthodontists to provide care that doesn't involve companies manufacturing aligners. There are a lot of applications that allow orthodontists to move the teeth themselves and either have the models printed in a lab or 3D printing in-house. And that can save our patients, especially ones that have minor irregularities, where those kinds of patients, we can provide, if we're not having to pay a lab an extensive amount of money, we could, if we don't have that lab fee, we can probably save our patients a lot and provide them care at a cost that's comparable to direct-to-consumer options. We all know that aligners have limitations. There are movements that aligners are just not capable of performing. And we need to get good at those hybrid systems that involve aligners with braces or aligners with other options, aligners with growth modifications, phasing it. We've been doing a lot of research on tunnel attachments, and they're basically, it's a hybrid between fixed appliances and aligners. They're basically attachments where you can thread a wire through to help you reach that predetermined virtual goal. And we've got some different cross sections for it. And there's a template to allow you to bond it to the teeth. So here's an example of a patient. She's a little bit open. And when open bite cases are great for clear aligners. She also had a habit, and we did give her some tongue reminders. But you see here, she's coming close to the end. And if you look closely, that lower right lateral incisor isn't tracking very well. It needs to extrude, and it needs its root to tip a little bit. And that's a movement that's extremely easy with braces, but extremely difficult with clear aligners. And having a system that allows you to benefit from both is advantageous in a situation like this. So we took what we set up on ClinCheck for her, and you could use this with any clear aligner system. And we moved the tooth to where we wanted, and you can see the tunnel attachments are passive at this point. And this is her wearing the aligners and the sectional wires to help upright those teeth. And the benefit of doing it this way is that the aligners and the wire are working completely in sync. So this is the other thing we can do is also remote monitoring, which Dr. Katebi is going to cover. But here, this patient was followed up actually during the pandemic. And you can see her starting to close up on that side where she was a little bit open and that lateral needed to erupt. And you can see here that from January to April, you can see that lower right lateral is leveled with the remaining teeth. And here's another patient. Again, this patient has very protrusive lips, an open bite tendency, some crowding, extremely procline upper and lower incisors. You need to take her face into consideration here. Even though the crowding isn't severe, she does need to have teeth taken out to bring those lips back. This is also someone that I was seeing, I was only able to see her a few times during treatment. And we have to treat her with aligners, but you can see aligners, this is what happens when you close extraction spaces with aligners. The molars tip forward. And we told her from the beginning, you were gonna need to use fixed appliances to get those roots parallel. So we virtually, in the ClinCheck, we corrected the inclination, the tip of the teeth, we got the roots parallel, but we knew the aligners weren't gonna be able to do that. So we set up these tunnel attachments with double wires. And we also monitored her remotely. You can see here between November and February, something that typically takes aligners multiple refinements to achieve, if you can achieve it, happened in just a few months. You can see here that molar uprighting with those tunnel attachments with the aligners. So, in summary, we kind of went through a few cases that show that you can achieve good results with remote monitoring, and some of the things we can do to help facilitate that. And then I'll hand the podium over to Dr. Katebi to talk to you about some of the tools that are available to help with remote orthodontic care. Thank you.
Thanks, Dr. Masoud. That was excellent.
Hello, everyone. Thank you for joining us today. I'm excited to be with you all, and I appreciate the opportunity to be part of this wonderful series. We are going to continue our conversation about the remote orthodontic care beyond the pandemic. Briefly, I have to mention that I do not have anything to disclose. Here is the outline of my presentation today. I will start by introduction to telehealth and teledentistry. Then I will share how I think our orthodontic practices got affected due to the COVID-19 pandemic. What are the available options and solutions out there that we can utilize? And I will finish with my take-home message. As we all know, COVID-19 pandemic has altered our economy, society, and healthcare system. On the flip side, the pandemic has also catalyzed the accelerated growth of telehealth, or the entire spectrum of operation used to provide remote care. So according to this recently published article, their takeaway message is, whether healthcare enterprises are ready or not, the new reality is that virtual care has arrived. So we better be ready for it. So let's talk about a little bit about telehealth in general. Telehealth has a very broad definition, and you may find so many different descriptive versions of it. Here I'm using the information that is provided by the American Dental Association, and according to them, telehealth is not a specific service and refers to a broad variety of technologies and tactics to deliver virtual medical, health, and education services. The next question that comes to mind is, how about patient perceptions of telehealth? I have to say that there are some studies that they investigated to answer these type of questions, and the results are very consistent with each other. Here I'm referring to this publication that was published in the American Journal of Managed Care in January 2019. So a group of scientists and clinicians here in Boston and Mass General Hospital looked at patient and clinician experiences with telehealth for patient follow-up care, and interestingly found that 79% of responding patients had a very positive experience with it and found it very convenient. Now you may ask, how is this relevant to dentistry? Which basically that brings us to teledentistry, which is under the umbrella of telehealth. And according to ADA's comprehensive policy statements, teledentistry refers to use of telehealth systems and methodologies in dentistry. Teledentistry can include patient care and education delivery using live video, store and forward, remote patient monitoring, and mobile health. So if you are participating if you're practicing inside United States and have any questions regarding services that you rendered during the COVID-19 quarantine time, such as which codes you need to use or how the insurance coverage works, then I would recommend to check out this document from ADA on the bottom of on my slide that was actually released on May 11th, 2020 in response to COVID-19 and coding, which I believe it is the latest version today, but as you all know, that might change soon due to all rapid changes around the COVID-19. It is very important to make sure that we are keeping our patients out of ER during the pandemic, and I believe teledentistry in dental practices and nursing homes can help to deliver patients, to divert basically patients in pain or any sort of dental or orthodontic problems from the ER. We can leverage it to help do our part in fighting this terrible virus. And similar to how I talked to you about the patient perceptions of telehealth, let's see how do patients feel about virtual dental care. According to a survey on teledentistry, which was completed before the pandemic in September and October 2019, 78% of patients said that they are ready to start using teledentistry. So that's a good news. Now let's focus more on orthodontic practices and how they got affected by the pandemic. So it is important to realize that the impact is not just on orthodontists, but our patients got affected by it as well. From their perspective, they will have a fear of coming into our practices. Demand to be seen first. I'm pretty sure you all have patients that are already in treatment and are expected to be seen as soon as your clinic opens up. Most likely, fewer patients seek orthodontic treatment due to increased unemployment. Our patients will have some extra time limitations as well. Right now, even running a simple errand takes much longer than before. Imagine time limitations when everyone is back to work, which changed working hours and other restrictions. And of course, there is a never-ending direct-to-consumer competition. From orthodontist point of view, we have to deal with regulations forcing us to reduce clinical volume due to social distancing and extra sterilization needs. We need to control overheads, increase costs, PPE, and most likely lower revenue. We need to create a safe environment for patients and staff, and it is super important to know that we need to be dynamic and ready for another possible practice disruption, which could be another spike due to COVID or any other catastrophes. So when we think about solutions to what I just discussed, and in regards to pandemic, we must consider the key phases of any crisis, which is respond, recover, and thrive, and consider them concurrently. When we are going through a challenging time, if we want to be successful, then we need to emerge more resilient on the other side. Therefore, my recommendation would be to implement strategies that they will not only sustain you today, but also prepare you for tomorrow and help you thrive in this new modern virtual era. So being creative with your virtual appointments will serve you well. So in order to come up with some solutions, first let's talk about what are the services that you can actually provide virtually from orthodontic point of view. I think preliminary exam and consultations fit beautifully in this category. You can take your time answering patients' and parents' questions, check the insurance status for them. Even some part of this visit can be done with your treatment coordinator to make sure your time is used more productively. We can review and monitor progress with aligners. I personally believe that patient compliance plays a huge role in the success of an orthodontic treatment. So we need to make sure that they are engaged and they are following the protocol that was given to them. Retainer checks can be done virtually, especially if no appliance adjustment is needed. We can evaluate growth and tooth eruption on those patients that we place them on observation. We can also use virtual appointments to assess appliance breakage and decide on the steps that need to be taken to address the problem more efficiently. As a first step to your virtual appointments, whether that virtual appointment is going to be for a new patient consultation or for a clear aligner check or for a retainer check, you are going to need some intraoral pictures. So here are some written structures that can be provided to your patients to help them take the intraoral pictures for you. There are basically two techniques, one using 2 spoons and the other one using 2 fingers to remove cheeks out of the way. And as you can see, the above pictures are taken with the spoons in this slide, and the lower one are taken with fingers. So you can also ask for some extra oral photographs, such as smiling, resting, and resting in profile, which you can also see in this picture. All right, now let's see how good my patients followed those steps. Here are intraoral pictures of 2 of my patients. They were given both written instructions and a link to a YouTube video that was made by an orthodontist who was showing the steps to take good intraoral shots. You can find more links if you look for them online. So what do you think about them? The top row is actually a patient in active treatment. So you can see attachments in her teeth. I think the shots are not bad at all. However, she's not biting down all the way. And for some reason, she thought upper and lower occlusal shots are not needed. So it's not giving me a whole picture. The second row is a child that has been placed on observation. Upper and lower occlusal shots are not bad. However, all the other 3, including frontal, right, and left buccal shots, are not diagnostic at all. She's not biting down, and also due to the spoon pressure, she is moving her lower jaw in the direction of the force, which is not helping as well. So this patient has a couple siblings. I see all of them, and each are in different stages of their treatment. So I wanted to see intraoral pictures for all of them, and that is what I asked from their mom. When I first received these intraoral pictures, I thought to myself that this is not working. The rest are going to be taken the same way, and I have to call mom to talk to her. While I was thinking about options in my mind, I received these second sets of intraoral picture from the same patient, as you can see here. It is a big improvement compared to the previous one. And I also can see a cheek retractor there. I also received another set of photos from her brother, which was equally good. When I did a little editing, such as cropping and changing the angulation of these pictures, they actually came out very decent, almost similar to the ones that are taken in office visits. So basically the lesson that I learned from this experience is that maybe a small tool change, such as providing our patients with some cheek retractors, might help us a lot to collect the information that we need. I also think if we use a guided tool that can walk our patients through this process, it will be helpful so that everything is in one place. If you think about available options that they can help you, I think first you need to decide which platform and technology would be most useful for you, your practice, your patients, and also your staff. Would you like to use an application, which you can ask your patient to download it to their smartphone and then utilize that? Maybe your most effective way of communication is through texting. Then you can consider a text-based platform. You might be interested in something that can be incorporated into your website and patients can click on it. In that case, you're looking at widget-based applications. Or you may be interested in using artificial intelligence. I also have seen practices that combine these available technologies and solutions. For example, they might use a service for scheduling and sending reminders to their patients, but also use another effective tool to recruit new patients. And on top of it, they are using the AI technology to monitor their cases, whether that would be braces or aligner. I have to mention that we need to do more research to provide more solid evidence when it comes to efficacy of new technologies and the claims that the companies offering them are making, so that we can be more confident in our clinical care. Here I summarized some of the most popular options that are commonly used by orthodontists here in the US and also around the world in order to basically I put them in the order that they were founded. As you can see in this table, each option has its own advantages and disadvantages. And I hope this helps you in your selection process. Again, some are good for new patient recruitment, some are very helpful for patient conversions, and some might be good for treatment monitoring. When you are weighing your options, please keep in mind that your staff also need to go through a learning curve with anything new that you introduce as well. So I would like to finish with a positive note that we are definitely going to come out of this. We are all together in this challenging time, and hopefully we can thrive out of the situation. I believe virtual consultations are here to stay. We were using them before, we are using them now, and I think we will be using them in the future. Please use the technology with caution and as a complement to your direct clinical exam and not a total replacement. Try your best to keep your patients engaged. The compliance is a very important ingredient to any orthodontic treatment success, and you need to make sure that you are keeping your patients engaged and compliant. To recent grads, if you are someone who graduated recently or going to be graduating soon, I want you to know not to be stressed too much about the situation and know that the golden era is still here, just got reinvented, and it will be up to you how to make it work. And last but not least, I would like to finish by a quote from Charles Darwin. It is not the strongest of the species that survive, nor the most intelligent, but one most responsive to change. With that, I would like to thank you all very much for your kind attention. Dr. Masoud and I would be happy to answer some questions. And now I would like to give the virtual podium back to our wonderful moderator, Dr. Klein.
Dr. Masoud, Dr. Katebi, thank you so much to both of you for these excellent presentations. You know, we are certainly living in an ever-changing situation, and it's helpful to gain insight and useful information on how orthodontic care can be provided both during and beyond this pandemic. There were several questions that have been raised from listening to your presentation, and I'd love to ask them to you now. Has this pandemic changed how you structure your thinking about functional appliance selection in Class 2 cases, particularly as we move forward in this situation where we may need less in-person appointments for a period of time?
So I can go first. So I think in terms of Class 2 and functional appliances, I use a lot of removable type of functional appliances. And I think they are very helpful, especially if we are not going to see our patients for a long period of time. So they are not going to basically work beyond that what is needed to be done. And I have to say, there are some cases that our hands are tied. For example, the patients are coming to us a little later, and maybe those appliances are not going to be as effective as possible. But in general, I think if a patient needs a functional appliances, the situation is not going to stop me from providing that type of treatment for them.
And yeah, I agree. I also use a lot of removable functional appliances, and there are situations where the compliance isn't great or you need to use something fixed. And again, depending on how long this pandemic lasts for, yeah, it probably will affect that decision where if you think you're not going to be able to see the patient for another 10 to 12 weeks, you might want to think twice about putting a herpes or a MARA in and having to deal with emergencies that you can't really deal with effectively.
Yeah, very true. I'm definitely thinking along the same lines in my practice as well. Another question that I'm curious to hear what you're both doing is how you're managing IPR, or interproximal reduction, in patients with clear aligner cases, both during this time and moving forward.
Well, I think when the shutdown happened, we didn't really know. I don't think anyone expected it to last this long or to be this involved. And we didn't know it was coming. So a lot of the cases that were in aligners had interproximal reduction that was scheduled, and we obviously couldn't do it during that period. And we just had to move on. And hope for the best. We're expecting that once we restart, hopefully soon, there are going to be a lot of refinements that are going to happen. We'll find out, but my guess is that there are going to be a lot of refinements because we had IPR scheduled, but we couldn't actually do it because of the situation. But in general, I think if we know you're not going to be able to see your patients regularly, I think it's a good idea to plan your IPR within the clin check based on how frequently you think you can see your patients. So I usually don't like doing IPR at the first appointment if I can afford to do that. But if our chair time is limited, then we might have to start doing it during that first appointment. If I know I'm seeing patients after 8 weeks, then I'll schedule my IPR at that point when I'm going to see them next time.
I completely agree with Dr. Masoud. I think we are on the same boat. The ones that they were already in treatment, there was nothing specific that we could do about them. But I think moving forward, that would be definitely something that we can plan a little bit better, thinking about what if we won't be able to see them for a long period of time. And I think also one thing that especially is relevant to this situation right now with creating aerosols is that maybe you want to consider doing the IPRs with the hand strips rather than using the hand pieces, so that you will basically reduce that aerosol creation. So that's my approach to IPRs for the patients anyways. I usually don't use hand pieces, and if you are not using that, maybe that would be something to consider. Beyond what just Dr. Masoud.
Right. A couple of questions have just come in about attachments, which I know is another thing to think through. Certainly for new cases that have come in when our practice has been closed, I've re-engineered the case and had a new case mailed without attachments. But what's your strategy for managing attachments right now? Are you treatment planning cases with less attachments and just planning for more refinements, or are you leaving the attachments on? How are you thinking about that?
That's such a great question. So for the ones that I'm actually doing refinements, most likely, even without considering the whole pandemic situation, I usually don't remove all the attachments. I'll try to utilize, basically I capture them in the scan and try to utilize them for refinement. So that won't really change. And I think in the beginning, we need to have to see our patients to deliver. So that first appointment is going to be still important. I think we can utilize that appointment to still place those attachments. So I think I won't change in regards to not having attachments at all. But also, I think the good thing about attachments are that if they break, they are not creating an extreme emergency or urgency for the patients to be seen right away. So if they break, I mean, the worst case scenario, okay, that tooth might not track as great, and we can basically capture it during the refinement, but it's not going to be a big inconvenience to patients or family members.
Yeah, I'd love not to use attachments, but I think aligners just struggle with like lateral incisors without attachments. They just don't track, unfortunately. So like Dr. Katebi, I know Invisalign recommends removing the attachments before you scan for a refinement, but unless there's a change in the type of movement we're doing, usually the refinement is just continuing the same type of movement that was planned the first time around. So there's no reason in my mind why the attachments have to go. Now, the exception is if they're optimized attachments and those have certain activation, and you could make a case for removing the optimized attachments and keeping the non-optimized attachments. But I think in general, the push surfaces you're creating with the attachments for the first round of aligners, the second round of aligners usually needs those same push surfaces to be there. So I generally keep them. I actually think the attachments work better the second time around because there's no error introduced with the indirect bonding of the attachments. You scan the attachments and then the aligners fit them perfectly. You don't have to have error involved in placing the attachments.
Yeah, I agree with that. You know, how has this pandemic impacted orthodontic education?
We're doing a lot more on Zoom, I think, like all other types of education. But I think we have the benefit in orthodontics where a lot of the skills involved in the specialty are diagnosis and treatment planning and things that can actually be effectively taught remotely. Now, you lose out on some of the clinical skill parts, but I think the majority of the specialty is diagnosis and planning, and our residents generally present all their cases before starting, during treatment, and at the end of treatment, and that's continued. So it's a problem-based learning environment, and I think we managed to do our best with it remotely. Even our clinical examinations, the case-based exams and the scenario-based exams, we ran all of those this year virtually, and it worked out surprisingly well. And I think it's a lot of those things that we did are probably here to stay because they were effectively done in a remote setting.
Yeah, I completely agree. We got actually very creative and innovative during this time. And I think some of the tools that we utilize, I think we would be able to utilize them later on. And we're trying to use our time a little bit more efficiently, I would say. In some cases, for example, now the clean checks are done via Zoom with one-to-one type of attention to the residents, so we can sit with them rather than being in the busy clinic floor. And I think it has provided some advantages. So obviously, if you're talking about any situations, there are advantages and disadvantages to any situation. Mm-hmm. But I think we learned some stuff from this experience. And it's been great having, alumni, orthodontists from all over the world coming, joining us, joining our case presentations and provide their insights. So yeah, we're happy with that.
Well, you all should feel proud of what you've accomplished, and the residents are really doing an excellent job of pivoting as well during this time. You know, we're really sorry if we didn't get to answer other questions, but unfortunately we are out of time. I want to thank our panelists, Dr. Katebi, Dr. Masoud, for their invaluable information. And thank you so much, everyone, for joining our session today. We have a lot of challenges ahead, but we're going to stay in this together. We hope you all stay safe, and let's stay connected to continue to navigate through this unprecedented crisis together. Any final thoughts, Dr. Kim?
Yes, on behalf of the Harvard School of Dental Medicine Continuing Professional Education Committee, I would like to thank our presenters and moderator for their expertise and for sharing their experience and insight. Today marks our final CP Today Talk series. We created this series in direct response to the changes in the field of dentistry that we are all experiencing together due to COVID-19. The mission of this initiative was to invite experts from different areas of dentistry to share the latest practical clinical information, as well as scientific research on how we can navigate the challenges we are facing as a dental community. For the past 5 weeks, we have covered a wide range of topics ranging from public health, geriatric dentistry, pediatric dentistry, oral surgery, periodontics, endodontics, oral medicine, oral pathology, and orthodontics. 17 moderators and presenters gave us deep insights into how we need to adapt to the new norm during this pandemic, but at the same time, they have encouraged us to find new opportunities to improve our patient care. For sure, the organizers of this series have gained a lot more as we spend many hours working with the experts via Zoom preparation sessions. Personally, I'd like to thank and recognize two special individuals, Ms. Tiffany Sarkisian and Dr. Jennifer Chen, who spent so much time and effort with organizing, preparing, executing, and editing these programs for our audience. For the past 4 CP Today Talk series, 1,800 dental professionals from 39 countries were able to tune in to our program. And we are grateful for you all for being part of our HSDM community. If you have not been able to join us for those previous talks, you can go to our school's website, www.hsdm.harvard.edu, and watch them at your leisure. Thank you so much for your trust in us, and we hope to see you in the near future, either in Boston or via virtual communication. And please visit our school's website for upcoming virtual courses for CE credits. And farewell, and we wish you all stay healthy and well, and thank you, everyone. Bye-bye.
Thank you. Thank you, everybody.
Thank you.
Thank you.